obesity in early adulthood was also seen with an increased risk. But moving on from cancer and their risk of obesity, we go to the efficacy of the new drug, niraparib, which is Zejula as well. Zejula is a drug used to treat ovarian cancer, and to test the effects of it, they ran through a phase 1 and also a phase 3 trial. Initially looking at the phase 1 study, Zejula demonstrated anti-tumor activity with doses of 80 milligrams or higher, with pharmacodynamic functional studies demonstrating PARP inhibition in peripheral blood mononuclear cells exceeding 50%. With the introduction of this drug with the patients, in total there were 534, and there was an increase in pulse rate from 24 and 15 beats per minute from the initial between the placebo and then the intervention itself of Zejula. 365 patients were given Zejula, and 167 were the placebo for the phase 1 trial. And patients received a 300 milligram once daily treatment of the drug. They showed no large changes in the mean interval. Once phase 1 progressed, they moved into a phase 3 double clinical, and they deemed patients that were eligible were over years 18 of age, and with ovarian cancer sensitive to at least 2 platinum-based treatment regimens. They balanced out the placebo, and then the control, or placebo was the control. It was a 2-to-1 ratio, so roughly 350 to 360 patients took Zejula, while the remaining took the placebo. So in the event of the 28-day cycle, it was found that hematological toxicity or thrombocytopenia patients, they were the most common side effect. So moving on to the side effects of the study itself. Nausea was seen most commonly, or was the most rampant one, but we saw the biggest increase in difference between the placebo and the drug itself for thrombocytopenia, which is the decrease in blood platelets throughout the body, and then in the ovaries in this case, which there was a 56% change shift between the placebo and the drug itself. And then other side effects included fatigue, anemia, constipation, vomiting, neutropenia, and headache. Of course, the most important ones seen were the thrombocytopenia and then the neutropenia, which are the most dangerous for some of the patients who had contracted and participated in this course. So moving on to the next.
To get more into the clinical cancer research, we went over the subtypes a little bit already. So I'm just going to focus on the subtype that we're focusing on, which is the high-grade serous carcinoma. And that is one that's clinically aggressive and has unclear precursors. And so we said earlier, this type accounts for 68 to 70% of ovarian cancer. 90% of this subtype is associated with BRCA1 and BRCA2 mutations. And there are 4 molecular subtypes, which are mesenchymal, immune, differentiated, and proliferative. And so this kind of cancer has a tropism for the omentum, which is the fat layer over your abdomen. And it has the worst prognosis of ovarian cancers. And we said earlier, it's the deadliest gynecological cancer. And one of the reasons it has one of the worst prognoses is because it's diagnosed at a very advanced stage, and it has chromosomally unstable malignancy, and the recurrence rate for this is greater than 75%. And so we just went over some of the trials. So I'm going to focus on 2 main trials that kind of show how this drug deals with progression-free survival. And so that's what both of these trials measured. They're both placebo-controlled, double-blind phase 3 trials. And the patients for these were advanced ovarian, fallopian tube, or peritoneal cancer patients. This drug treats those three kinds, or it's been approved for those. And so the treatment groups, obviously, the ones taking Zejula, and the control is the placebo group. And so the two trials are the PRIMA trial and the NOVA trial. The PRIMA trial measured how it was working in patients who were homologous recombination deficient. And we talked a little bit about that already. And the patients in these were patients who had already responded to platinum-based chemotherapy. So that meant that chemotherapy was already kind of working and slowing the progression of their cancer. So in this trial, 733 women whose deficiency was unknown, so they either had it or they didn't. And then there were 373 women who were definitely positive for the deficiency. And so in the unknown group, 38% showed a less risk of progression when given Zejula, and in the positive group, 57% had less risk. So they both showed an improved median progression time with the drug, but definitely the ones who were HR deficient had a better outcome. So in the NOVA trial, instead of HRD, they measured whether or not, or the effect of this in people who had a BRCA mutation and people who didn't. And so these women had recurrent ovarian cancer, and they had at least 2 platinum-based chemo treatments, and they also had already responded to chemotherapy. And so 553 women took part in this trial. 372 were in the treatment group. And there were also 2 groups, the ones that had the BRCA mutation and ones that didn't have an inherited BRCA mutation. And so these results showed that Zejula slowed progression for 55% of the women who did not have a BRCA mutation, and for 74% of the women who did have a BRCA mutation. So kind of like the HRD positive study showed that this treatment worked for both groups, but it definitely had a better outcome for the people with the mutation or the deficiency. And so that explains some of the subgroup benefits. So 24% of HRD positive women responded and saw shrinkage. So that kind of shows the cytotoxic effects of the drug. And 50% of this response lasted over 8 months. So that means they had 8 months without progression. And then the women with recurrent ovarian cancer in the NOVA trial, they had 4 times the median survival time or progression time if they had a BRCA mutation, and 2 times the amount of time if they did not. And then there was another study done that shows that it doesn't really matter what age, really, the drug still worked and had similar effects for people greater than 70 years old and people who were less than 70 years old. So just to get a little bit into the development of the drug, the dosing, we said about it a little bit earlier, but it's a 1 capsule that you take orally every day. And often it's reduced. So they start with the max dose, which is 300 milligrams. So you take 3 of the capsules, and often people go down to just 1 capsule, which would be the minimum because that's the minimum dose. It's 1 capsule. And so niraparib is a PARP inhibitor. It targets the PARP enzyme. We talked a little bit about it, and we learned about this in class, but basically it uses synthetic lethality against BRCA1 and 2 mutations because it prevents single-strand break repair which allows double-strand breaks to occur, which results in cell death. And so a study done showed the drug combinations, and this drug has been shown to work well with 1 kinase inhibitor specifically, which is the c-MET inhibitor, and that potentiates the effect of the drug, but some other kinases like the PI3K inhibitor didn't work as well. And resistance is actually not a huge issue for this drug. Prolonged use has been found to actually not cause resistance, but there has been some cross resistance due to the chemotherapy that the patients are on as well. And this drug also induces G2/M cycle arrest, and it affects other cells as well. So it's not completely specific to cancer cells. And so 43% ended up discontinuing this drug due to adverse effects. or 21%, that's a typo, 21% discontinued, but 43% had these serious adverse effects. And the main effects, we talked about those a little bit, but the main ones were nausea, thrombocytopenia, which is a low platelet count, anemia, and fatigue. And these are due to the concentration of the drug. So likely, a lot of times when they'll go down from 300 milligrams, they'll do better. And also, some of these were already caused by the chemotherapy. So it's kind of a double effect. Okay, that's all we have. Thanks for watching.
Have a great night.